Oral finasteride and topical minoxidil, the true drugs that allow the battle against hair loss to be fought on two different fronts, are the established, scientifically proven, and uncontested present-day gold standard for the management of hair loss due to androgenic alopecia. Though a widely acclaimed gold standard, this drug combination has never been the flavor of the month. To rational, intelligent minds, medical consensus carries more weight than the endless speculations, constant ramblings, and misplaced opinions of trolls, cyber stalkers, without medical credentials on various hair loss forums. But since when have facts come in the way of business interests, you may ask? Companies will continue to reinvent the wheel, put old wine in new bottles, just for profit. Vested interests in this billion-dollar hair loss industry will continue to confuse you, confound and slander cheap and effective cures for baldness. Well, it's so ironical that a drug that works through the oral route is being denigrated in favor of a topical form. On the other hand, a drug that is US FDA approved for use in its topical form is being castigated, and its oral form, which is even more toxic, is today being eulogized and universally promoted. Can anyone figure out what's happening? Aren't we relentlessly flogging a dead, dying horse in an attempt to perfect something that is old? Something that was scientifically dismissed a long time before? Well, there are simpler solutions to the problem that needs to be perfected. The same drugs, if perfected in delivery systems, if perfected in strategizing the way they are consumed, can themselves alter the effectivity quotient in patient response. Just a simple example is this video, the 5 strategies that you need to adopt while optimally utilizing low-dose finasteride, is a video I made some few years back, in which with low-dose finasteride, we can obtain the same gains that we would with the full dosage, all in an effort to minimize the appearance of side effects in those who are susceptible. On the flip side, it is no longer a hidden fact that in hair loss research, because of duress and miscellaneous compulsions, companies and individual researchers have fallen into the endless trap of jumping onto the next big thing. The next big thing that promises profits. Researchers seem to be busy all the time since so many years, but nothing seems to have come out of the research. And in this, the hamster wheel comes to mind. An activity that involves somebody being busy all the time, but never achieving anything that is noteworthy or even reaching the end of the task. Effort going into vain due to needless, not well thought of pursuits. The need of the hour for medical research into hair loss is to reverse this mindset and get integrity back into medical research for hair loss. It is very easy to dismiss old treatment on flimsy logic and calculations. It is an accepted fact that drug companies are not going to allocate funds to clinical trials into something which will not bring in the profits. And research into oral minoxidil will never make a drug company richer, since it is an old drug. Are we not aware that many things that we consume are killers at high doses, but safe and efficacious when taken in low dose? Take for example alcohol that most people drink routinely. Alcohol can kill you in high doses, but we are unmindful of the fact and enjoy it very often. All said, evidence is building up in favor of oral minoxidil, a heretofore obscure treatment for hair loss, as being a far better choice over topical form of minoxidil when used in low dosage. To summarize the use of minoxidil for hair loss, minoxidil is an approved medication for treating severe recalcitrant hypertension, since it is a potent vasodilator. And its chief side effect includes the salubrious effect it has on hair growth due to androgenic alopecia. Minoxidil is a prodrug. It is activated by the enzyme hepatic dehydroepiandrosterone sulfotransferase, or SULT2A1, to minoxidil sulfate the active principal compound. Oral minoxidil doses of 2.5 mg and 5 mg produce peak plasma concentrations of 16.8 and 37.2 nanograms per milliliter within 30 minutes of post-dosage. Side effects include hypertrichosis, lower limb edema, postural hypertension, and tachycardia. Topical minoxidil is approved by the US FDA for treatment of hair loss. Topical minoxidil is also a prodrug or a pre-drug that is converted in the hair bulbs by thermostable phenol sulfotransferase or SULT1A1 to minoxidil sulfate. There is considerable intersubject variability in the levels of both hepatic SULT2A1 and follicular SULT1A1. Low SULT1A1 predicts weak hair growth both with topical minoxidil and oral minoxidil. Weak hair growth due to low concentration of follicular SULT1A1 can be overcome by using oral minoxidil by dose escalation, but cannot be overcome by topical minoxidil due to low solubility and saturation absorption kinetics. Low dose 0.25 mg oral minoxidil have been proven to have virtue in the treatment of female pattern hair loss when used in combination with spironolactone. On the other hand, oral minoxidil in the doses of 2.5 mg to 5 mg a day has many votaries on various hair loss forums, and in the medical fraternity, support is building up in favor of the use of oral minoxidil. So now talking about sublingual minoxidil. Sublingual minoxidil is mostly the same as oral minoxidil. The only difference being the process, the way by which they go systemic. Sublingual versions of drugs in common use abound. Drugs like Zofran, Ambien, Claritin, and a whole lot more. The most well-known being NTG. Systemic minoxidil seems to be better for treating hair loss, but has a greater propensity for ill effects, however low in incidence they may be. However, the side effects that we often read about happen at very high doses, doses which are not used for treating hair loss. And due to this reason, this oral route was earlier dismissed for treating hair loss. So a little about minoxidil. Minoxidil is a pre-drug or a prodrug, as some people call it, that needs to be converted into its active principal form, minoxidil sulfate, by the enzyme sulfotransferase. Whether we are deficient in the enzyme sulfotransferase or not cannot be predicted without checking the levels of SULT1A1 gene. If you wish to know about the conversion of topical minoxidil and the SULT1A2 for the oral version, the best conversion happens when we take minoxidil in the sublingual form because it bypasses the liver. Minoxidil gets round the first pass metabolism in the liver to get converted into the active form minoxidil sulfate in the hair follicles. It begs the question, why would anybody prefer oral over topical form if there are so many risks involved? Well, only if there are more benefits. Several renowned physicians who very commonly treat hair loss in their practice stand by oral minoxidil without reservation, stating that it is of more utility than the topical form in treating hair loss. Dr. Rodney Sinclair's treatment with sublingual form of minoxidil and that of Dr. Pathomovich for oral minoxidil have been encouraging. Oral and sublingual minoxidil are emerging today as popular treatments for hair loss in low doses, and they may soon prove to be a game changer. Oral minoxidil is a cheaper medicine that is affordable by most people and also can be covered in medical benefits. I myself have been using oral minoxidil in my patients for a few years now and find that the use of a topical minoxidil is very frustrating for a majority of the cases. For 5 reasons. Number 1, topical minoxidil does not work for everyone. Topical minoxidil gives most folks dry dandruff. The topical form cannot be used when there is pre-existing skin disease in the scalp like psoriasis, like dermatitis, and many more. For topical minoxidil to work, you have to have the enzyme SULT1A1 in the scalp. And lastly, topical minoxidil is messy to apply and makes the hair look dry, coarse, rough, and unkempt. So low-dose oral minoxidil is fast emerging as a mainstay in the therapeutic ladder for male and female pattern hair loss. In my practice, I still recommend topical minoxidil as the first line of treatment, given its well-established safety and efficacy profile. In non-responders to topical minoxidil, I do try applying 0.1% tretinoin. 0.1% tretinoin is known to increase the activity of sulfotransferase in the scalp. and this may turn non-responders into responders. I consider low-dose oral minoxidil 0.625 milligram, 1.25 milligram, 2.5 milligram, and even at times 5 milligrams in a day if there is a poor response to application of topical minoxidil for 6 to 9 months after initiation of the treatment. As minoxidil is a prodrug, it needs to be activated by means of the enzyme sulfotransferase to its principal form, minoxidil sulfate. And this can happen either in the liver or in the hair follicle. Sublingual minoxidil, if Rodney Sinclair, the principal researcher in its use, is to be believed, seems to have better bioavailability and fewer cardiovascular hemodynamic side effects because it avoids first pass liver metabolism. So will sublingual minoxidil be a game changer in the treatment of hair loss in females and men? Well, time only will prove this. Though Rodney Sinclair is making a good case for sublingual minoxidil in the use of hair loss, and he has the patent for it, it needs to be seen if it will displace the much more affordable generic oral minoxidil, which is also covered through medical benefits. However, Rodney Sinclair's study lacks in certain parameters. The size of the study is negligible, it is not prospective, and it lacks a control group. As of today, it is unclear how the two, sublingual and oral minoxidil, will compete. So keep watching this channel for further updates on medical treatment for hair loss and for hair transplant. If you have any question, any thought comes to your mind that needs clarification, do drop a comment in the comment section below and I'll be there to help. Thank you for watching and God bless you.